All right, good morning, everyone.
Good morning.
Good morning, good morning, good morning. My name is Ime Ekpenyong.
Can't hear it.
Really? No, seriously.
No, I'm just.
Okay. I mean, we just met, so I don't even joking or not. Ime Ekpenyong, CEO of SGRX Health. With me today is a couple of my colleagues, Karen Kiewski, Director of Business Development and Project Management and everything else that there is. And Carla Powell is our Director of 340B Administration Services. We're going to be the team doing some of the talking today. In addition to this, we got a couple of other folks in the crowd that are from part of our SGRX family. So I'm going to have our Director of Marketing Services introduce the team.
Yes. Hi, I'm Jenny Hammond, and Damalola Adabal and Brittany Cochran are both on my team. And then Ernest, do you want to?
Yeah, my name is Ernest Wilkin. We are the communications agency at 98 Forward for SGRX. I'm here today with Sherry Holly and Timmy Boston. And Tony. I'm Antonio over here at the video.
Yes.
No way to go
video
the
man.
best side.
98 Forward is an agency that we partner with for marketing, PR, everything PR and marketing services. Great people to work with. So what we'd like to do is just have each person go around and just briefly introduce yourself, name, organization, and your role. Starting with the great, I'm not going to say your name. I messed it up, so go ahead.
Good morning, everybody. I'm Tim Codd. I'm honored and blessed to be a consultant for SGRX, and I was introduced, a little over a year ago by the Director of Labor for Henry Ford Health System Health Alliance Plan. And one of the things that I found with SGRX and the relationship that we've established was their response time and how they addressed the problem, which I think we're going to find out a little bit more about today. But as I was sharing with Luke, I've had some tragedy in my life. I think everybody's touched on it some way, some form, somehow, with opioids. And I lost a younger brother and left 2 kids. He was an accountant, former athlete, got started, and unfortunately it didn't end well. And what I have been working on in my world was mostly collective bargaining agreements. So any municipality, any large corporation, like Ford, GM, and Chrysler, they bargain benefits. And what we found out through data was that population, surprising to them, that 25% of them were on an active opioid. And of that 25%, it represented almost 20% of their spend. So to prevent one opioid prescription based on the University of Michigan and the Market Scan database, which is an all-payer database, lagging, albeit maybe 18 months, that one opioid avoided post-surgical will save an employer up to $8,000 a year. So we presented that with the collective bargaining units in the Michigan Building Trades to SGRX. And within 4 to 5 months, SGRX responded and became the only PBM in the entire country, and specifically the state of Michigan, the only PBM in the state of Michigan, that is non-opioid directive compliant. Which, again, has some meaningful impact because we're all affected. So I'm very excited to be a part with Amy and Vicki and introducing it to the world.
Thank you, Tim.
Tough to follow that. Good stuff, Tim. Luke Trofio. I work with a local benefits consulting firm called Lavasco Group. We work with small to medium-sized companies on the commercial side, helping them manage healthcare costs for their employees. The groups that we typically work with have anywhere from 100 to 1,000 employees, mostly headquartered here in Southeast Michigan. But yeah, excited to be here. Learn about 340B and SGRX.
Thank you.
I'm I'm Rebecca. I'm one of the nurses at Macomb County Health Department. We work in the STI HIV clinic, helping our community stop the spread of STIs and HIV.
Bianca Clark, I'm an advanced public health nurse, and I'm also the health program supervisor for the Macomb County Department.
My name is Emma Hamoud. I'm the COO for Wayne County Health and Communities. We're a federally qualified health center, and we are looking to expand to include the 340B pharmacy. So I'm excited to be here and learn more about this.
Yes.
Debbie Price, I'm with Ottawa County Department of Public Health, given planning and SGI program.
Welcome.
I'm Mirka Cardoso Garcia. I'm from the Calhoun County Public Health Department, working in the STI program and family planning.
I'm Artist Jackson, Wayne County Health Choice of Michigan. We provide health care for all the small businesses throughout Wayne, Macomb, and Oakland County. And it is a pleasure for us to be joining in with Script Guides starting in the first of the new year, and I'm excited about it. I've been with our program 32 years, and so new, fresh faces and ideas is very exciting for me.
Thank you.
Hi, I'm Stacy Shaw. I'm from Health Choice of Wayne County, and we run Health Choice of Michigan. I am the Quality Assurance Department Manager, also a registered nurse. So I do a little bit of everything there, grievances to whatever. I put you in.
I forgot, I'm the Department Program Manager. That's here for it.
Yes. Thank you. Did we miss anybody? All right. Beautiful. So we have a great, diverse group of attendees. SGRX started these series. I think our first one was a couple of quarters ago, where we just focused on the PBM industry and some of the challenges. And we decided the next one we're going to do is focus on the critical component of the pharmaceutical industry, which is the 340B program. So, I thought it was AI. That means that's next. That is next. All right. Next slide. All right, so what we're going to start with is just an overview of the industry and some of the challenges that the space is facing. Before we do that, who here has never heard of 340B? So, yeah, this is family. What?
I've heard of it, but I could use some education.
Okay, all right, two. That's not bad. See, if you've heard of it, I need you to stand up and so 340B program was established approximately 30 years ago. The term 340B came as a specific code within the Public Service Act of 1992 that came up, and it was done in an effort to have certain institutions get access to discounted medications. Those institutions include hospital systems, federally qualified healthcare centers, specialized clinics, STD clinics, HIV clinics, the Indian service centers. There's a component of it in Hawaii also. But these are organizations that serve the vulnerable. So the primary purpose was to help ensure that individuals in indigent populations get access to discounted pricing. And what has happened is, a lot of scrutiny has come to the industry because of the lack of transparency in how the funds are being used to ensure that it's serving the audience it was intended to serve. And that's coming from large hospital systems to small entities to TPA partners to PBM. So the whole industry is getting scrutiny right now, which is why there are like 20 to 30 bills, currently right now to scrap 340B. And like any other industry, it's because, again, there is a challenge right now with transparency. When this law was written 30 plus years ago, there wasn't a lot of details around, the regulatory aspect of it. It was done, everyone had great intentions to make sure it circulated, but then over a period of time, the abuse factor came into play. And in every industry, there's always going to be one or two bad apples that make it hard for all of us. For example, it started with only one contract pharmacy. And those of us in here that understand 340B know what I'm saying is, as a 340B entity, you're allowed, when it started, just to have one contract pharmacy partner that you can work with so that your patients can access that medication. But over the past 20 plus years, it's evolved to where you can have multiple partners. And one of the biggest changes that drug manufacturers now are regulating the amount of contract pharmacies that you can have. Meaning that if you are for example, if you're a clinic that has an in-house pharmacy, they're regulating, there are a few manufacturers that says you cannot have a contract pharmacy partner. And just to take a step back and explain what that means is, so as an institution, you have to have a mechanism to ensure that the patients have access to their drugs. And the primary way to do that is either you have an in-house pharmacy or you partner with an independent pharmacy. It could be an independent, a large retail chain, but that is the primary mechanism to make sure that your patients have access. From a criteria standpoint, the patient has to have a record with that institution to be able to get access to those drugs, right? And the physician writing that prescription has to have a relationship with the institution. So if you're a covered entity, which you would have gone through HRSA, which is the Health Resources Service Administration, which falls under the Department of Health and Human Services. They are the regulatory body for the 340B program currently. You go through that organization to get certified, and once you get certified, again, be it a federally qualified healthcare center or a hospital system or a state program, as I mentioned earlier, to be able to get access to those drugs, you're going to have to get a wholesaler, right? Once you get certified, you need to have a wholesaler relationship. And these are organizations like Cardinal and AmerisourceBergen, McKesson. You have to partner with them. And then you're going to also either manage service, the TPA services in-house, or most times subcontract entities such as us, to be able to manage the ecosystem. So there's a wholesaler, there's a pharmacy, and then there's a TPA like SGRX in the middle to help make sure that everyone is being compliant. See, everyone just looks like you got it. So, question?
Yeah. If I'm a federally qualified health center, or I'm in health services, and I'm able to provide pharmacy, I buy at a discounted rate off of the depot, whatever.
Right, the wholesaler.
The wholesaler,
Right.
I sign up with you. What does that mean for me?
That means that you're going to be able to realize program income. We'll talk about that in a couple of slides.
Okay.
So you're going to be able to realize program income from the fact that you're purchasing at a discounted rate compared to market. 340B prices are about 60% below the market price.
So, great, that was my next question, right? So now I'm a collectively bargained Taft-Hartley.
Right.
And I have membership all over the state of Michigan. And I use SGRX. How does that fit into a federally qualified health center or Indian Health Service clinic in optimizing this value?
We're going to talk about an example in a couple of slides, but let me tee it up though.
And we didn't practice this.
Yeah, I've never met this guy. No, I'm kidding. That was a joke again. But essentially,
this is relevant to the world that I'm.
Essentially, what also transpired a few years after this act was, put into place is that the FQACs are now able to partner with payers, be it a government entity or an employer program, to be able to optimize the program. Under one premise, right? The patient still has to be eligible and comply with the rules. Meaning, if it's a GM, let's say GM, I'm going to use a huge example, right? Partners with your FQAC. Any of their patients there, as long as that employee is seen a doctor that's affiliated with your clinic and getting a prescription filled at a pharmacy affiliated with your clinic and has a record of having been seen there within a certain amount of time, they'll be eligible. So what's happening now is entities are partnering with clinics and hospital systems to be able to optimize that price. Because again, from a pricing standpoint, it is really the lowest, the most aggressive discount out there, right? As a, in our world, we get to wear multiple hats. So for clients, we typically will compare. We'll pull your data and we'll say, here's 340B, here is International Pharmacy, here is Mark Cuban's program, here is our traditional network, to be able to determine what's the best pricing component for a customer. And 9 out of 10 times it's 340B. Let me pause, because my folks are going to say I'm talking too much. A couple of different things that I wanted to address for those of us that currently have 340B programs. The first is the rebate model. So to the point I mentioned, the way that entities such as the clinics and the hospital realize revenue is that they buy. This is the simplest way, and this is I've been in this industry for 20-something plus years. This is not meant for you to grasp everything here. What we want to accomplish here is just put it out there and then follow up so we can give you more information. But at the end of the day, they buy at a low price and really, dispense at market. And only these entities are allowed to do that. No one else other than the approved organizations can get access to that discounted price, because you're allowed to use that spread between what you bought for and what you sold at to reinvest in your community. That was the whole premise, is that differential between what you're making is supposed to be reinvested, and the issue is everyone is deciding how they reinvest that money, right? So what the industry is trying to do is, set some kind of transparent standard so that, everyone has, because again, the whole goal is not to use taxpayer dollars for this. It's the manufacturers that are being squeezed, for lack of better words, to be able to provide the discount. And don't feel sorry for manufacturers, they're doing just fine. But the transparency is causing a lot of mistrust for something that is
The lack of transparency.
Yeah, the lack of transparency is causing mistrust for something that's meant to do good. And folks are trying to take it away, which would make healthcare worse. Trying to think what other ones that I need to address from a timing standpoint.
What happens when you're not compliant?
You lose your certification. And, HRSA is, has a resource problem, so they are not auditing as often as they would like to. One of these bills is actually, proposals out there right now is to shift the regulatory body from HRSA to CMS. So CMS, Center for Medicare and Medicaid Services, has more resources to audit more often. That's a good thing for smaller FQACs because nobody wants an audit, but as part of the regulatory, to be able to let the society know that there are eyes on this program and the dollars are being managed efficiently, there has to be a certain amount of audits from the regulators to be able to convey that confidence. But right now, folks have been audited maybe once a year or so. So there's a proposal to shift the regulatory body from HRSA to CMS. And then lastly, one of the things that recently impacted, this is an example of where it could go, as of 2023, 2024, during the Biden administration, most folks are aware of the cuts to insulin, which is good. It actually, reduced insulin price to somewhere between $35 to $50. But what ended up happening is 340B spend went up significantly from about $2 billion 20 years ago to about 60 plus billion in 2023.
What?
And that's a combination of hospitals and FQACs coming together to order. That's how it's tracked. The manufacturers are tracking the discount that they're giving to these entities. And about 10% of that is diabetes. So if these FQACs are using that, and it's critical, it's a critical program income mechanism for these hospitals that are serving vulnerable populations to stay afloat. That's how they're generating it. Either they get 340B money or monies from their state, depending on what state you're in, that goes. So those dollars are critical, for them. So when that got cut, the unintentional, impact on the clinics and the hospitals is that their revenue got strong. Because it's not, 340B pricing, there's no real differential between what the cost of insulin is anymore. And so that just, I'm trying to bring things full circle for you to understand that even though it's helping, there are situations where, some of these unintentional changes will impact the program. So the goal now is to diversify the program, look for different ways to optimize revenue in the most compliant manner possible. Next slide. Okay, this is about us. We're essentially a TPA that started out focusing on PBM services. Company's been around for about 25 plus years, privately held. We have, our core services are 340B, pharmacy benefit management, insurance benefit management, which is a combination of medical claims management and also pharmacy. Broker services, we're also an agency, so we partner with our clients to be able to, with our government clients that require enrollment in programs such as Medicare Part D, ACA. We manage from as of 2025, 24, I'm sorry, we manage over 200 million, I know I said that out loud, 200 plus million in pharmacy spend across different government sector and employer sectors that we work with. Michigan-based, proud minority and women-owned business, and then last but not least, we launched our own discount card program called SGRX Saves, which is also another way to optimize the 340 program. So we have our own version of GoodRx called SGRX Saves. The types of clients we have, 340B entities, health plans, government programs, self-funded, and we've been very blessed, in our government sector to retain 100% of our clients over the past 10 years. Our strength, transparency, and the lowest cost model, that really sums it up, right? So everything we do is in the best interest of our customer. We do that well, we get paid, right? And a critical part of that is looking at the different pricing optimization opportunities. 340B, discount card sales, marketplace, Mark Cuban's discount program, international pharmacy. We don't own a pharmacy, so there is no conflict of interest. Our goal is what is in that customer's best interest.
Ime?
Yes, sir.
Again, sorry for the question, but isn't there a lawsuit out there regarding a PBM owning a pharmacy?
A lot of states are, a lot of states are prohibiting that right now, because what's happening is it is killing independent pharmacies because the PBM industry is a $500 billion industry that's dominated by 3 players. That's 90% of the market, 3 companies. And those 3 companies own mail order, specialty, so when they become the PBM for an employer group, the goal is to directly or indirectly push you to their pharmacy.
Or a municipality, right? It could be an employer group or
an employer group. The goal is to push you, what does that do? Hurts the little people, right? The independents. So yes, but there's no federal, anything being done federally. I mean, there are things proposed, but states are going, taking acts to be able to do that. Thank you. We currently work with covered entities across 12 different states. We work with FQAC, state government programs, and within those state government programs, the HIV programs, PrEP programs, STI programs, and our services can be looked at in 2 different forms. We provide a full TPA service, and also we lease our state-of-the-art software that we, proprietary tool that Karen's going to talk about in a few slides here. And then, as I mentioned, we have about 12 different jurisdictions. So what I would like to do here, just to get you all pumped up, is who can tell us exactly what state this is? Just down here. No, you can't do 98.4. Okay, no, did you see this? No. Okay, 98.4 is fine. No? Oh, what? Who said that? Beautiful. You're the winner. Hawaii secret. Yeah. Hawaii. I like that. This is new, so well, maybe the next will be a trip to Hawaii. Okay. How about this state?
Tennessee.
Tennessee?
Tennessee.
Yeah.
Tennessee.
Yeah.
Can you point to Michigan?
I know that.
Yes. Jenny printed this for me.
No, he did.
So great, man. I was supposed to cram it this morning, but that didn't work out. Okay, one more. What about that one? I need a hard one. Which one is going to be difficult? This one? Okay. This one?
Yeah.
That one. That's the last one. Who's got that one?
Oklahoma or Wyoming.
She got to get something. That's two. Okay, beautiful. All right, I think that concludes my,
Was it Nebraska?
she was right?
Yeah.
No, you were right, I'm sorry.
Oh, okay.
No, you are definitely the winner. Yep, okay, I think people are getting really stressed now. I got it. Let's do this. So that's Montana, Wyoming, Utah, Nebraska, Hawaii, Mississippi, Tennessee, Michigan, Georgia, and the last one?
South Carolina.
God, this is a wonderful crowd. Okay. All right, so next I'm going to have my colleague Carla come on and talk about our existing solutions and what we've done to be able to help our clients optimize their programs. Before that, any other questions about anything you just heard? Thank you.
Okay, thank you. Good morning again, everyone.
Good morning.
All right, so the services that SGRX provides to our 340B clients, we're going to go through what those services are, and then we'll move into how we help our clients optimize their 340B programs. So the goal, of course, is to save your staff time and to automate your solutions to your 340B program. By doing that, you are able to care for your patients. I know a lot of 340B covered entities struggle with having enough staff, and managing a compliant 340B program can be difficult if you don't have the staff in place to be able to do that, as well as do your day-to-day patient care. So that's where SGRX comes in at helping manage the 340B so that you don't have to do that internally. So contract pharmacy management. We manage the contract pharmacy relationship from start to throughout your program management, running your program, from the negotiation of the contract with the pharmacy, once you identify a pharmacy partner that you would like to work with. So we help to manage that contract negotiation, the credentialing, and the registration support. So those of you that have a 340B program and you have a contract pharmacy, probably familiar with the process of having to have that pharmacy registered and approved in OPA before they can start dispensing medication to your patients. So we can assist with that entire process in helping you to get the pharmacy set up and ready to go. Inventory management. So we manage that entire process as well for some of our clients, from the replenishment with the wholesaler to the tracking and reporting aspect of the inventory, and also the true-up management process. So many of the clients have a time frame in which the medication needs to be replenished to the pharmacy. And if that cannot happen for one reason or another, maybe the medication is discontinued or just unavailable at that time from the manufacturer, then there is a process in place to then unqualify that claim as 340B, and then there will be a true-up process. So we manage that entire process as well for many of our clients. So we would be the ones that would assist in setting up, these accounts with the wholesaler and then going into the wholesaler account to actually place the replenishment order medication and have that shipped directly to the pharmacy. So again, from that entire process from start to finish with the wholesalers, we're managing that inventory. All right, so with the wholesaler management, we are doing at minimum monthly desktop audits to just confirm that the 340B pricing that your covered entity is being charged for the medication is in fact actually the accurate 340B price. As some of you may know, so the pricing with 340B changes quarterly. So these negotiated rates they can fluctuate. So we need to just ensure that the wholesaler has the correct pricing in the system. So as we are doing our desktop audits for the programs, we're just making sure that you are receiving the actual 340B price at the time that the prescription was filled or dispensed. One other thing that we do is the invoice management. So we support paying the wholesaler on behalf of our covered entities. So we would take that, the invoice that is generated once we place that order with the wholesaler, we would pay that on behalf of the covered entity, and then the entity would, of course, be invoiced for that, as well as the TPA services after. Auditing support. So you may have mentioned the importance of compliance. It really is very important with 340B, as you may know. So with 340B, if you do not remain compliant, covered entity can lose their eligibility for 340B. And if you lose that eligibility, you may or may not be able to get it back. So it's really important to work with a partner that is going to ensure that you're being compliant based on all of the rules and regulations that HRSA has for 340B. So we work with you with your policy and procedure to make sure that it is reflective of what is compliant with 340B rules and regulations, and then help you to manage the program in that way as well. So we do, for some of our clients, we do on-site audits ourselves. So we'll go out to some of their clinics or locations, and we will do audits there for the covered entity to make sure that their partners are being compliant, because ultimately the covered entity is responsible, even if you have partners that you're working with. And then also the internal audits. So we'll do virtual audits, we do on-site audits, and also we assist with a HRSA audit. Because again, as you may mention, HRSA will audit at some point. It's not really a matter of if, but when the covered entity will be audited. And when they do, we're there to assist through that process, providing any documents that they request, and just helping you walk through that entire audit process and ultimately, have a successful audit. And patient referral capture. So with referrals, so if you have, again, a patient that is a shared patient, so a patient of the covered entities, but also someone that may be a patient of a prescriber that you have a relationship with, some type of a professional relationship, then that patient can be eligible for 340B at your covered entity. So we just help to identify where those opportunities are. We can verify that referrals are being captured. So if you refer a patient out from your organization to, let's say, a specialist, maybe an oncologist, for example, that you have a relationship with, as long as your patient's care remains at your organization, and it's documented in the files and everything in the EHR, then that referral, that prescription will qualify as 340B and generate revenue for your organization, but we just need to make sure that it's captured referral and that it's documented appropriately. And that goes back to compliance as well. So there's a certain way that you have to do that. Again, we can help manage the referral process. And again, just making sure that you are prepared in an audit, if you are capturing referrals, that those referrals actually do qualify as 340B, and that we have the documentation for you to prove that that is actually your patient. Under patient management, we are helping to manage eligibility. So with our clients, we have to have access to your eligible patient list, so that's either by you providing that information to us, either electronically, or us connecting to your eligibility platform. And then we use that to determine, the eligibility for 340B. So all of this really is going back to compliance, right? It starts with compliance. If these patients are not on the eligibility file, getting prescriptions filled, and we're generating revenue, that is definitely a problem. So we're managing eligibility. As mentioned, we have a discount card. So we can also set up a discount card for those patients that are uninsured, so that they can realize a discount at the pharmacy. And then we also offer medication therapy management. Data management and reporting. So again, we have tracking systems for reporting, and we are managing those things, customized reporting. So we have clients that may have specific requirements for their reporting, especially if it's a government entity and they have different reporting requirements that they have to meet. We can help to customize the reports and the layouts to meet those requirements for reporting. And our system is compatible with EHRs. So what we learned by auditing many of the locations throughout the state is that a lot of locations have different EHR systems. So our system will be able to, it's compatible with EHR systems, so we'll be able to feed the information into our inventory tracking system, and also to help us be able to capture those 340B eligible claims. So next, we're just going to go over a couple of examples on how we are helping our clients to optimize their 340B programs through partner relationships. So there is a document, a memorandum of understanding. So if a covered entity establishes a relationship with a non-340B covered entity, and they have this document that basically will be outlining what that relationship will look like. Then those patients that are going to the non-340B covered entity, by partnering with the covered entity, they're able to capture those claims as 340B eligible. So we have a couple of examples here. So one being, we have a client that has a hospital partner. It's an oncology doctor, where the client does not provide oncology services in-house. So they partner with a local hospital that is not 340B eligible, and those claims for their patients that were written for oncology medications then can become eligible for 340B. So they're able to bring in that revenue for those claims as well. One other example of a payer covered entity partnership. So we have a client that is partnering with the local Bureau of Corrections, so that the clinic's provider, prescriber, is seeing patients at a prison. And because the provider is eligible at that location, those patients that they're seeing at the prison and writing prescription for, they're also eligible for 340B.
And just to add, sorry, in that case, this entity is not even doing it for program income. That prison system was purchasing at retail. And now because of their partnership with that FQAC, they're paying half the price of the drug. And then the FQAC is seeing their patients and making money from the copay, the medical visit. So it's a win-win for both parties.
How do you find that out, whether it be in Macomb County or Wayne County or Oakland County? Whether those correctional facilities are optimizing or not?
Well, optimizing or not, that's not public, you have to, that's getting in. But as far as whether or not they are, because some prison systems have 340B certification through the Department of Health. We were just presenting to the state of Montana's Board of Corrections, and they actually are certified covered entity. But if you go into the office, the OPA site, it has everyone that's covered. So every hospital in Michigan that has it, that's public information. And every prison system that has it, that's public information.
Thank you.
And just some more examples here of our audit support. So again, HRSA audits, we have a client that successfully completed a HRSA audit. There were no findings, so we were able to work with them throughout the process to provide all of the information that the auditors requested. Do on-site audits. We have a client that we do annual on-site audits for. Some of you may be familiar with our organization because of that, because us working with the state to do those on-site audits annually on their behalf, just to make sure they remain compliant. And then virtual audits, we do some audits virtually where we will set up teams so that we can cover more of their locations each year. And then some of you may have mentioned this earlier as well as we were talking, but we also have a client where we converted their entire process from being very manual, very fax this, email that, to being completely electronic to manage their inventory. We did that with our 340B Flex platform. Any questions? Okay. Thank you, Karen.
So now we're going to shift a little bit more into how we accomplish all of these things. Carla and Ime have talked about the different programs and the services related to that, but now we want to go a little bit into the technology that we offer to address this. I do know that there's a few attendees here that are very familiar with the 340B Flex application that we offer. And our 340B Flex application is really intended for when there is a centralized inventory management. So in this case, the entity has a central warehouse, and they manage all of the inventory from there, of their own replenishment. However, each of the local health departments need access to that medication. And so the local health department employees can log into our system, place orders from that warehouse. Those get disseminated. And then as well, in that application, to tracking of the dispensed medications to ensure compliance with all of the audit requirements. And then, of course, the customized reporting. The demo that we're going to be providing today is kind of on that next level application, SGRX 340B Flex Plus. And so Flex Plus is very focused when you have dispersed inventory management, so when you're working with contract pharmacies. So this includes a lot of what you've just heard from Carla about the different requirements in order to remain compliant. So the claims qualification, the wholesale ordering, the replenishment, and then of course always all of the reporting that's available. So at this time I'm going to take the presentation down and we're going to switch over to our demo. Excellent. So this is our SGRX 340B Flex Plus. For those of you that are familiar with Flex, you're going to see some things that look a little bit familiar. It's kind of the same back end. This was created really with the user experience in mind, wanting to make this something that's easy to use and easy to understand, however, provides you all of the information that you need. So when you log in, you can see that this is, generally pharmacy specific, because again, it's about managing the inventory at those very specific contract pharmacies. So right now we're just using a demo of a pharmacy in Eaton Rapids, Michigan. From a navigation standpoint, I just want to call out, we've tried to, again, make this somewhat Excel-like, because Excel is, a platform that most everybody's experienced with. And so there's things that you can do to help narrow down and make your searching easier. So right now, if I just enter a name. Oh goodness, live demos. One moment. There we go, just needed to refresh. So now you see just by, if you're looking for a specific member, again, by typing their name, their last name, or a member ID, you'd be able to focus very quickly on that specific member that you're looking for. To get more information on that member, again, that's going to pull up the member information. And what Carla mentioned is our integration with your EHR system. So we would work with you to understand what are the points of integration, whether that's, you know, an export and import into our system, or if we can have that direct feed. You know, we've worked with EHR systems. In some cases, we have clients whose eligibility platform is CareWare. So where we can have that direct interface, that's what we would like. So again, the information that comes in through the eligibility would then be visible here on this screen. And then you can drill even further down to see the specific claims for that member that have been captured in the system. So now I'm going to So I'm going to walk through the different tabs that are around here. And again, this is going to correlate to all of the different items that Carla spoke about of what needs to be captured to ensure compliance so that you retain your 340B qualified status, and then all of the things that need to be captured and why this application helps bring all of those things together. So you've seen the members, so that's pulling in your eligible members. Next is pulling in the claims to determine which are qualified claims. And again, going back to what has been mentioned several times, those different factors of it must be an eligible member, seen by an eligible provider with a prescription filled at an eligible pharmacy, and a medication that is on your 340B medication list. So those are the 4 factors that we look at on all the claims that come into the system to determine is this a qualified claim or not. So on the claims, just again, when you click to look in at the claim, it's going to bring in all of the details of the adjudication of that specific claim that was brought in from the PBM system for this. Oh, I'm sorry. And again, here there is, you know, the different claims reports that are available. And that's going to open up in the next tab. And the claims report will allow you, that's quite an eye chart, but there's a lot of data in there. And it allows you to be able to pull that out. And one of the things that we hear on a regular basis is the ability to export this into whatever format you want. Again, a lot of times our clients want to export this to Excel because sometimes they need to take this data out to be able to manipulate and create their own internal reportings. So there is always an easy way to extract the information out of the application. And again, of course, we also know one of the other main requests was, you know, claims by prescriber. So that's just another report, again, that will do all of that, but now it's going to list it by prescriber. Under the provider tabs, these are going to be the providers associated with your program that are the qualified providers within your system. Again, you can see, you know, a user with the correct rights would be able to identify those that are, you know, active or not active. Again, this can be imported, you know, if you have a large list of providers, or you'd be able to administer this as you need. The same applies to the prescriber table. Again, this is, you know, you can mark the prescribers that are eligible here on this list, you know, whether or not they're active. So again, this is, as we look at all of those claims, the points that you need to pull in to identify, is this a qualified claim for the 340B pricing? As I mentioned, there's generally a list of the medications for your program that are included on your 340B pricing list. And so that would be all captured here. So again, when the claims come in, we can identify, yes, that is a medication that is within the program with the right prescriber at the right pharmacy, so this is a qualified claim. Under locations, this is generally if you have multiple clinics or health departments, that's what we identify as locations. And so we try to make this system as customizable to your unique program. And of course, on this one, these are the orders then that get placed on behalf of the pharmacy to replenish their 340B inventory. What this does is, based on the claims that have come in, we know that their inventory was reduced on those 340B drugs. The system will automatically calculate what orders need to be placed, generate that in most cases into an EDI file with the large wholesaler to have that process go out to the wholesaler to ensure that the medications can be delivered to the pharmacy to replenish their inventory on whatever basis that needs, whether that is a daily, sometimes we're placing up to 2 orders a day, weekly, again, whatever is unique to your environment, we can make sure that we can sustain that. And again, just calling out all of the information that becomes very easily available. So, and being able to export this to use how this is fit within your environment. So with that, I'm going to bring the presentation back up unless there's any questions about the application itself.
Thank you, Karen. So I think Karen mentioned that that was a user-friendly tool, but we also wanted to make sure, because we have clients that range from small FQHCs with 1 person, with no IT, so we wanted to make something that was simple enough, but also, most importantly, HIPAA compliant, right? So from an access standpoint, so those were 2, we have this is a proprietary system that we own. Again, one of the things that's unique about us is a small, or we have to use small anymore, boutique. Boutique organization is that, we own a lot of our systems. So, and this is an example of where there's no middleman between us and our customers. We manage everything in-house, and any opportunity we get to be able to have the technology to support that is an example of where we can do that. And we built it with customer feedback. Our first major 340B client was the state of Michigan. And they currently, I think one of the programs we work for them, the STD program, has about 80 different health clinics across the state that we manage. And, the number one, objective is to ensure that the state and its partners are compliant. And that's what this tool does. It brings everything together. It looks at the whole ecosystem, the providers, the wholesaler, to ensure that, everyone, because again, the savings are significant, but, from an the administrative burden is significant also. So to keep your certification, to keep your status, you have to make sure you're compliant, because an audit can change that overnight. Yes, sir.
Can you explain that relationship with the state and the 80?
So the example I just gave, we do a couple of things for the state. This one, and I may need Carla or Karen to jump in, but essentially the Department of Health has an CDC grant for STD drugs. What are we talking about? Yes, it's a CDC grant for STD drugs.
Yes.
Can you talk about the, sorry.
So that relationship with the state of Michigan, first of all, there's 96 locations now that we're managing inventory for. So this 340B program is unique in that it is not generating revenue for the state. They are giving all of the health departments and their partners throughout the state in-kind medication, meaning at no cost. So all of the health departments are able to place orders in 340B Flex for any STI medications that they need to have on hand for their patients. So they're doing the inventory management, they're ordering, they're dispensing, they're doing all that within the platform. And that's the one that I mentioned we brought from being a very manual, faxing over orders, emailing, very manual process to getting them to be electronic, which saves those health departments a ton of time, from what we hear, but you all feel free to share your feedback.
It was night and day between what we were using before and now. I mean, it's like one click to get your quarterly report done, whereas you had an Excel sheet of like, it could take you an hour, now it's one click.
So you're benefiting
Oh,
as a county from a program that they have under contract at the state. Why isn't there a press release on that?
And that was not planned.
No.
I don't know who invited
He
me
was
to
in
this.
Carlos
So I kid you
earlier.
not, just like it wasn't planned, so I didn't really,
So thank you for
we
sharing.
haven't met some of you in person, didn't realize that, so anyway, thank you for that. That's good to hear in person, thank you. And then we have another program with the state that has a revenue generating model. That's PrEP is an HIV prevention medication, and what the state also has funding. So these entities can either do this through an in-kind donation or through a grant. So the state has funding for that purpose, but they need an administrator to work with the pharmacy. So what would happen is the individuals go to the pharmacy to get the medication, and most of them are insured, but they just cannot afford the copay. Right? So you go in for PrEP, prevention, can't afford the copay, the pharmacy processes the claim through your insurance, this program picks up the copay, but again, because that drug was purchased at 340B price, but the insurance company reimbursed the pharmacy at market. Right, everybody following? So, reimbursed the company at market. The difference between the purchase price and the market price is the revenue. It's the program
It goes back
to
to
the state. And what the state is doing is sharing those funds with the different counties that they're working with.
So would you get a benefit from that financially?
50%.
Yes, Yep.
Wow.
Yep. So the state is sharing that with the person. So there is,
I do not want to hijack this at all, but I've been asked, are you familiar with MPHI? So there's a quest, right, a challenge with MPHI to intersect public health with private health. Because if the vulnerable population in the private sector fall victim to whatever, they become public health. So they're trying to close that chasm right now, and they've selected a number of individuals from the Michigan Association of Health Plans, which is the Medicaid health plans. They've asked me to sit, because I represent the collective bargaining units. And this is an example of one of those intersections, right, of actually taking public health, optimizing the value that you have through this program. That could be step one. So I know Macomb and Wayne County, right, this could be, wow.
and that same model is what we're trying to do in the commercial sector, right? But do it in such a way that, again, it benefits those in need.
Yeah.
Right? So, because what's happening is, again, you have 340B people benefiting, and I don't want to say names so I don't look like in cities that, high wealth cities, people they're using that's not what it's meant for, because the hospitals are finding ways to navigate, the eligibility criteria, and, so that's what's causing, that's why the transparency is important. It needs to go to the folks that need it, and it needs to be, transparent. As I talked about initially, the patient eligibility piece is what is being scrutinized also, because again, HRSA is saying there has to be a record, right? And record is determined by, there has to be a record of that patient being seen at that entity, at the FQAC, at the hospital. Some FQACs have in their policy manual once a year. Some have once every 3 years. there's nothing in the statute that was put in place 30 years ago that spells that out. So there's a lot of noise around, okay, why would you use a 3-year time frame and still benefit from the program? Because, so there's a lot of scrutiny around that, but most entities use at least one, but you as the clinic or the hospital determine what that is. If you get audited, you just have to make sure it's in your policy and procedure. But they're still, HRSA is frowning against a longer time frame. I just read something that the American Medical Association considers one visit in 3 years as compliant.
So if you're getting 50%, right? And the big beautiful bill's cutting all of, there's a lot of opportunity that they're seeing in cost reduction, so-called, right? And you have a 50% relationship with a program like this. Not to say that it would recover what the big beautiful bill's taking away, but it would have an impact.
Right. I just learned about 340B prep.
Wow.
We benefit from those in-kind transactions with the state currently. But under 340B prep is my interpretation, or we were told that we have to use that 50% revenue that we could potentially gain. We have to use that to reinvest in the community, right, that we service. So, like you said, it could be used to buy more testing supplies or buy more medications that maybe aren't
Where you're actually seeking a budget for.
Right.
Cover that enhanced population.
That's the good part about it not being spelled out in your statute, right? Is that you can, as long as you're doing good with it, you know, as opposed to using it for something other than reinvesting. So, but yes, it's a huge, so we still have there are a few entities locally that don't have certification, so, but it's a huge, especially with the current climate, the bill, the cuts that are coming for Medicaid. 340B is without, if optimized in the most compliant manner possible, can help fill some of the gaps in these underserved areas. So that's the connection that we're trying to help bring about is, okay, these cuts are coming, some of them already hit, but if you're in a situation, there's some hospitals that have never even thought about 340B, this is the time. We have helped, we don't talk about that a lot here, but we have helped, some entities from ground zero that never had it, so we have the resources to help you start if you don't have anything in place today. It is like a 6 to 12 month runway. I mean, during COVID, they were, turning it around a lot quicker. But it's heavily scrutinized. They have to make sure that they have to look at your data to make sure you're serving a vulnerable population, which is typically going to be Medicaid, uninsured.
So do these, that we call it, have Medicaid contracts with Medicaid health plans?
We don't.
They don't have to, but they see the
Programs do.
patients. They're uninsured, right?
So they're uninsured.
We take anybody. We don't need to look at insurance at this point.
What an opportunity.
But in terms of diversifying income or revenue, this would be an option for us if those big beautiful cuts or big beautiful cuts. if they greatly impact us next fiscal year, then this would be something that we definitely have to consider billing and utilizing.
Where are you located?
Macomb County.
What part?
We have 2 locations, so one in Warren and then one in Mount Clemens.
Oh my gosh.
We have the family planning program has a Medicaid program, they used to be 340B entities.
And that's the key, we have to be, with Medicaid, because, one of the compliance issues is what's called duplicate discounting. So you can't use 340B and then also collect rebates. So
So let me ask you
there has
this.
to be a lot of conversation with the Medicaid.
Because what we are doing in Chicago, right,
Yes.
with an organized labor unit, then I can say this, I have permission, the Teamsters, okay? And you're finding potential clinics to optimize 340B in Chicago.
Right.
So we are working with the municipalities in Macomb right now, these cities, and under a program called My Life, where the cities have joined, if you will, a collective bargaining, and they're going to send out bids for a third-party administrator, whether it's Blue Cross or Henry Ford, et cetera. But they're gonna be putting out a PBM. And wouldn't that be a,
Yeah, I see where you're going with this. But yeah, it's the same,
I mean,
it's
the
the same
city
model.
manager and the county executive would love to hear this kind of a, right? And I think the same thing would exist for
Mark
me.
So even with.
Mark Wackel, I mean,
He's our boss.
no, and I say that because he's really conscious on the budget, like, seriously. And I think we're all, concerned about that, but if we can optimize this, what a great strategic meeting.
We've been looking at it for.
Well, I'd love to, and the same thing with Assad and Mr. Evans. I think,
We're Health Choice, so we provide a health plan for small businesses within Wayne and Oakland County. But I believe someone over there is from the health department, correct? Okay,
Yeah.
QHC. So that would be a great opportunity.
that'd be awesome.
Yeah.
So we have started.
Yeah.
Yeah,
Oh, you did?
No, I said
No,
we
you
should.
should.
Absolutely, I'm seeing him on Friday. Well, he had a sudden loss. His niece, which is public, just passed. Yeah.
We've started some of those conversations because,
When I was at JDF, we did have a 340B.
We did, okay.
Yeah, I think we were the only one in Wayne County at that time, but the medical, I don't work there anymore, but the medical director who the license was up under her, she no longer works there. So I think they let it expire.
I let it expire.
But it's worthy of
Mhm.
optimizing.
Yeah.
But from a health choice standpoint, partnering with the county FQACs to be able to
Yeah,
make,
for our
it would
members.
allow us
Yeah.
to make more medications available,
Yeah.
right? Because
Correct.
you know the way the plan is set up, but
Mhm.
things that are not even covered, they would be able to get access to at the 340B price.
Mhm.
So
And
it could
create
make the program
revenue
a
for
lot larger.
these centers,
Yeah.
which are so budget dependent, right?
Correct.
Wow.
So, that brings us to the end of our presentation. Any other questions? Again, this was done in a way to be able to create, we started these series a while back, to help create visibility around what we're doing. We've been around 25 plus years. And again, we've been blessed to grow into different markets over the past, 11, 12 years, but put a lot of emphasis on the government sector. And that emphasis on the government sector is what got us into 340B. And we're now in a good position to be able to help optimize savings for our commercial partners, our government partners, and it's a very rewarding experience as a for-profit organization. So we want to be able to help you wherever you need it. So as after this, we'll discuss how we can collaborate. And please share information. We'll follow up with you after this presentation and give you anything else you need to be able to get your programs going. Any other questions?
Wow.
No? All right, well, thank you everyone for coming. We appreciate you. Have a good rest of the week and maybe
Good luck at noon. Share with them what you're doing at noon.
Yeah, we